Hi, I'm at ASH 2019 at our annual meeting, and I'll be presenting at this meeting a really interesting abstract that is presenting the data from a phase 2 clinical trial adding navitoclax to ruxolitinib in patients with primary or secondary myelofibrosis. This is a novel study, and we're presenting the data from the first 34 patients. We know at this time that there are no drugs approved after JAK inhibition in patients with myelofibrosis, and we still need better therapies. Some strategies include using small molecule inhibitors that have other than JAK2 targets, and other strategies include adding on to ruxolitinib therapy. This particular clinical trial looks to add on to existing ruxolitinib therapy to try to increase the response with this combination in patients with myelofibrosis. Navitoclax is an oral BH3 mimetic that selectively targets cancer cells that are dependent on BCL-XL, BCL2, and BCL-W. There's very interesting preclinical data in myelofibrosis models that suggest that BCL-XL inhibition would be beneficial, and that combination with JAK inhibition looks to be synergistic. In this clinical trial, patients have to be previously on ruxolitinib therapy for at least 12 weeks prior to coming on, and thought to be considered to have suboptimal responses to ruxolitinib. Navitoclax is added at a dose of 50 milligrams daily and up-titrated weekly up to 300 milligrams based on platelets and tolerability. And the primary endpoint of this study is looking at the splenic volume change at week 24 compared to baseline. And primary endpoint includes looking at other responses such as total symptom score reduction, bone marrow fibrosis, and so forth. In this clinical trial, eligible patients include those that have been on ruxolitinib for at least 12 weeks prior to coming on study, and had to have been on a stable dose of 10 milligrams twice daily of ruxolitinib for at least 8 weeks prior to coming on. Patients in particular have to have a palpable spleen of 5 centimeters or greater based on exam, and no one could have accelerated or blast phase disease. For the first 34 patients that came on study, what's really notable in this cohort is that 50% of the population carry a high molecular risk mutation. And of the 50% that carry a high molecular risk mutation, half of them have 2 or more mutations, which portend poor prognosis for these patients. Patients on average had received ruxolitinib prior to coming on study for about 21 months prior to study entry, suggesting that this is a heavily pretreated population that should have already achieved their best response with ruxolitinib therapy. Patients on therapy also include those that have primary or secondary myelofibrosis, and half the patients had primary disease and the other half had secondary myelofibrosis. In terms of the activity and safety that we saw, we were able to take a look at splenic volume reduction over time, and what was really notable is that although we saw 30% of patients achieve SVR 35 by week 24 in 30% of patients, meaning a splenic volume reduction that was clinically impactful, if we look at best splenic volume response over time, we were able to appreciate that it was closer to 43% that actually achieved responses, suggesting that with longer follow-up and beyond week 24, there can still be benefit. When looking at total symptom score, which is another clinical readout for symptom response, we were able to appreciate that patients had a significant reduction in their total symptom score in half the patients. What is also notable is that patients were able to tolerate the addition of navitoclax therapy. Patients on average were able to be on navitoclax for about 330 days, suggesting tolerability for an add-on regimen in patients that are thought to have resistance to underlying JAK2 inhibition. 80% of the patients coming on study had a higher ruxolitinib dose of greater than 10 mg BID coming on, and most of them required a dose reduction down to 10 milligrams twice daily, which is thought to be a biologically active dose. Of the patients that came on study, the majority were able to tolerate, and over half were able to up-titrate up to the 300 milligrams daily dose, suggesting that we were able to maximize potential response for patients. Of the patients that discontinued therapy, only 2 were thought to meet IWG criteria for disease progression, and otherwise only 3 adverse events led to study discontinuation. When looking at the safety profile, overall the therapy was generally well tolerated. What is notable, although the common AEs include thrombocytopenia and diarrhea, those were primarily not high-grade events. And in fact, with thrombocytopenia, which was an important readout for us, in particular because megakaryocytes are so BCL-XL dependent, one would be concerned about it. What we were able to appreciate was that there was only 1 grade 4 event with thrombocytopenia attributed to navitoclax, and that when looking at platelet levels over time for patients on study, they appear to plateau by week 6 to 8, suggesting that if we're able to dose titrate patients based on the protocol's modifications, we were able to get patients through very transient thrombocytopenias that were indeed very manageable. When we look at over time how patients do, the median platelet level at week 8, which is where most patients plateau with their platelet count, is roughly in the 90,000 range, which is indeed quite tolerable. In terms of bleeding events, no clinically significant bleeding events were appreciated. In terms of other clinical aspects that are important to us, we look at leukocytosis, and we were able to see normalization of the majority of patients' white blood cell count over time. And further, when looking at something called disease-modifying benefit, which is one of the holy grail of responses to therapy in myelofibrosis, we were able to appreciate that about 1/4 of our patients experienced bone marrow fibrosis reduction based on local evaluation of bone marrow biopsies, which was highly encouraging. In fact, 1/4 of those, half of those patients that experienced a bone marrow fibrosis reduction had 1 grade reduction, and the other half had at least 2 grade reduction. Only 1 patient had an increase in bone marrow fibrosis out of the 34 patients, which is highly encouraging for the combination altogether. So in summary, with the phase 2 data that we're presenting at this meeting, we're able to see that a combination approach with adding on to ruxolitinib with a drug like navitoclax, which is a BH3 mimetic that primarily targets BCL-XL, is a really reasonable and interesting strategy. The safety data looks to be highly encouraging, and importantly, there appears to be clinically meaningful outcomes, including splenic volume reduction, improvement in total symptom score, activity in patients with high-risk molecular mutations, also early evidence of bone marrow fibrosis reduction. And this is really important because it primarily was in patients that have been previously heavily pretreated with ruxolitinib therapy. So I think that there's a lot of hope for us that we could gather more information with time. There will be additional study with this drug as a monotherapy and in combination in the myelofibrosis setting that is ongoing, and we hope to report more information on this at future meetings.